So our next speaker is Dr. Bamidele Kammen. Dr. Kammen has been a physician at Children's Hospital Oakland since 2000. She obtained her medical degree at Harvard Medical School and then completed a 4-year residency in radiology at Hospital of University of Pennsylvania, followed by a fellowship in pediatric radiology from UCSF. So Dr. Kammen will be here today to help us do some radiology review for pediatrics. Thank you, Dr. Kammen.
Absolutely. Thank you. I'm just going to get set up here and then we can get going. How's everyone doing? Hanging in there? Woo! Okay. Okay, here. That should work. All right. Thank you for your patience. So, the title of, first of all, thank you to the organizers and the chairs for inviting me. I'm really honored to be here. So the title of my talk is called The Limping Child, the Good, the Bad, and the Ugly. So I have no financial disclosures. So the limping child is a common indication that can be a challenge for all of us. And so imaging in conjunction with the clinical and laboratory data can provide an accurate diagnosis, hopefully. So my talk, we're going to focus on the etiologies and the appropriate imaging evaluation. So by the end of this talk, you should be able to describe indications for the use of different imaging modalities, build an appropriate imaging algorithm for the acutely limping child, and also determine a differential diagnosis of common as well as uncommon etiologies for the limping child. All right, so let's get this going. So this is the interactive part. I want you to point your phones and use the QR code, or you can join at slido.com. And can everyone just sort of type what your specialty or subspecialty is? Let's see who's in the audience. And so this is going to be a word cloud. So the more people that we have in a certain, so sports medicine, yay. All right, it's coming up. Pediatrics, wow, a lot of pediatricians here. Okay, family medicine, sports med, athletic training. Okay, great. Well, we have a pretty diverse, people are still typing, this is great. Okay, so, family medicine. So I think peds and family medicine, as well as all these other, great. Well, welcome everyone. So there should be something in this talk for everyone. Okay, so why do we image? So imaging is going to help us in aiding in obtaining the diagnosis, helping us determine the etiology of the limping child, and also guide management and treatment. I first of all want to briefly talk about the different imaging modalities. So X-ray, ultrasound, CT, MRI, nuclear medicines, their strengths and weaknesses. So X-ray is based on the principles of the attenuation of the X-ray photon, right? And so an X-ray basically is the initial imaging modality for most extremity injuries. There's no prep necessary. It's readily available, it's economical, and it's ideal for a fracture, as we can see in this film. With the X-ray beam, when something is not dense, it's going to go right through the film, such as air, and be dark, whereas with bone or metal, you're going to see increasing density. And the disadvantage of X-ray is that there is ionizing radiation involved and is limited for soft tissue detail. So ultrasound, based on the principle of using the echoes from high energy sound waves to form images. So the advantages is that it's readily available. There is no ionizing radiation involved. It's ideal for patients, and sometimes you'll see us in that room chasing the patient around. We can characterize soft tissue very well, tell the difference between fluid and solid by using Doppler ultrasound to look at the vascularity, and it's a problem-solving tool. The disadvantages is that it's very operator dependent and there's a steep learning curve. And also it's very limited for looking at bones, right? So in this image that you have, this is taken from the lateral aspect of the knee. And so this is the femur and the tibia. And so you can see the edge of the bone, but you can see that everything past that is shadowed out. So we're not going to see bone marrow. Okay, this is a foreign body that we can see really well, surrounded by edema. So CT, it's using X-ray and computer processing to give us cross-sectional detail. Okay, so we have excellent, exquisite anatomic detail. You can see in this image, you can see the trabecular markings, you can see the fracture going through. So we primarily use it in the setting to look at bone and for lesion characterization. We can also get 3D multiplanar reformations and spin those in space to get more information about what we're looking at. Disadvantages, it does use ionizing radiation. It's relatively more expensive, and it has very limited soft tissue detail. MRI, so magnetic field resonance imaging, using hydrogen protons within the body, within a magnet, and the energy they impart to develop images. So advantages are we have exquisite soft tissue resolution. It's the imaging of choice to look at bone marrow. We can look at other soft tissues like cartilage, tendon, and ligaments. So in this sagittal view of the knee, we can see the muscle as distinct from the fat, as distinct from ligaments, the posterior cruciate ligament, and then we see the marrow. We see how exquisitely we see the calcium as well along the patella and the distal femur. Disadvantages, it's limited in availability, it's expensive. You're placing someone in a confining tube and it's prolonged, and so that's hard for children. Many of them are going to be required to be sedated or have anesthesia. It does less well with bone detail than CT, and it's very motion sensitive. So someone has to lie very still for a long time in the magnet, and it's also metal will give you a fair amount of artifact. In the nuclear medicine, we heard a little bit about nuclear medicine from Dr. Sabatini. So where a small radioactive material is attached to a carrier molecule to target a specific tissue. So here we have a bone scan and the molecule is targeting bone. And so you're gonna get areas of increased uptake in any area of where you have increased bone turnover. So it's very sensitive. So here you can see this increased uptake in the mandible and in the femur, but it's non-specific. So it's used for screening, for detection and localization, for tumor follow-ups in osteosarcoma. The disadvantage is that there is ionizing radiation, there's poor spatial resolution, and what you're seeing is non-specific. It's gonna need further imaging. Okay, so we're working in partnership, right? The radiologist with you, the providers, and we really rely on an accurate clinical history. Okay, so Mark Twain said, the difference between the almost right word and the right word is a really large matter. It's the difference between a lightning bug and lightning, right? So there was this interesting study out of radiology in 1988 that looked at the impact of clinical history on fracture detection with radiography. And 7 radiologists were asked to read 40 studies, okay? And for some of them, they were given history, and for others, they were not given history. And so their interpretations when they had localizing history was much more accurate than those without. So what we rely on from you is the what. What happened? What was the history? Where? A lot of times we'll get requisitions that just says pain. So if we know, okay, where the point tenderness is, we can give you a better interpretation. When it happened, and if there's prior imaging, have your patients bring the prior imaging in with them so we can compare. Okay, so here is a 14-month-old who's refusing to walk. She has no localizing symptoms and no concern for infection. What would you order? And we're gonna have a little poll after this. Would you order x-ray of the total lower extremity, 2 views of the femur, tibia, fibula, and pelvis? Or x-ray, 2 views of the tibia and fibula, or an x-ray, 2 views of the femur, or x-ray of the feet, or a hip ultrasound? So I'm gonna have you answer that on the next. No comments from the peanut gallery. No localizing symptoms. Okay, you guys are great. Okay. All right. So some saying hip ultrasound. No, not hip ultrasound. Tibia and fibula. X-ray the whole dang leg. Okay. All right. Okay, good. Well, let's talk about this. All right, so the next, I'm going to use the ACR appropriateness criteria as a guideline for this talk. Okay, so the ACR appropriateness criteria are guidelines, evidence-based guidelines for providers to make appropriate initial imaging decisions. And it really enhances the quality of care and it makes efficacious use of radiology. And you'll notice here that it says up until the age of 5. And This is typically true for kids up until the age of 5, but it does apply to older children as well. And so during this talk, you'll see examples with older children. So there are 5 variants, 1 through 5, and they're based on whether they're localizing symptoms. And you can see that variants 2, 4, and 5 do have localizing symptoms, whereas variants 1 and 3 do not have localizing symptoms or concern for infection. So variants 1 and 2, there is no concern for infection, and variants 3 through 5 have concern for infection. So now going back to this 14-month-old who's refusing to walk without localizing symptoms and without concern for infection, that is going to be variant 1. Okay, so what it says is that radiograph of the tibia and fibula is usually appropriate as the first imaging line. And so why is that, right? So you're just playing the odds, basically, okay? So this paper out of Pediatrics in 2008 actually looked at the utility of total lower extremity radiographs in the investigation of non-weight bearing in the child. And what they found was that tibia toddler fractures were the most common explanation for non-weight bearing. So that is a good place to start. Okay, and then if there's nothing there, you can go to the femur and the foot. And that's a little bit controversial, but here's what you can do is if you're sending your child in with this that's limping, you can say on the requisition, start with the tibia and fibula, and then if we don't see anything, do the femur and do the feet. So what I want to now show you is what the things we're looking for. And some of this is going to look familiar because Dr. J showed this same thing. So here's our 14-month of this limping. We're going to cone down. And what do we see? We see this oblique fracture in the distal tibia. So this is your classic toddler fracture, okay? And then some of you may have the question, maybe you don't need to follow up if that's what you think it is, but if you do need to follow up, when do you want to follow up? So you're going to want to follow up in about 7 to 10 days because this is actually a 4-week follow-up where we're seeing some resorption around the fracture line. You can see some sclerosis around that fracture, and then you can also see here the periosteal reaction, okay? So, and I'm going to show you other places you can look at on the tibia and fibula view, and that are going to be areas, or going to be the type of fractures that we see. So I'm going to come down here. You can probably see here, there's a little buckle, and here in the tibial tubercle, there's a little buckle here as well. And so this is the compression or trampoline fracture. Kids come in after being on a trampoline or being in a bouncy house with this compression type fracture. So that's another type of fracture that we're commonly seeing. And you might say, but wait, there's usually a normal depression here, right? So where you have the unossified tibial tubercle, and it can be hard to see at times, but if you have any hint of buckling or acute angle at all, then that's what it looks like. And you'll see the sclerosis around that on follow-up films. Oh, okay. So this is not to forget to look at the edge of the examination. Okay, you want to look at the tarsal bones, and that's usually the cuboid. You want to look right there at the cuboid because in this toddler, there's sclerosis at the base of the cuboid. So you're seeing it right there. And so this is another kind of toddler fracture called in the cuboid. And that occurs because when children start walking, they're initially toe walkers. And so you can see that that cuboid is getting crushed between the calcaneus and the base of the metatarsals. So that's the other place to look. Okay, so in building our differential diagnosis with trauma, we've seen a toddler fracture of the tibia, the trampoline fracture, and the toddler fracture of the cuboid. Okay, let's go on to variant 2, where there are localizing symptoms, but no concern for infection. So the only appropriate initial imaging is area of interest radiography. So what I'm going to do now is just use variant 2 and build a differential diagnosis going from the pelvis to the foot. So I want you all to look at this and then tell me what the diagnosis is. So this is a 4-year-old boy with limping and pain in the right hip for the past 4 weeks. What's the diagnosis? Did you see that? Was that long enough? No, sorry. Okay. Type it in, Dr. Sabatini. You're okay. All right, so you can type it in now. Okay, so we have Skiffy, we have Perthes. No, really skippy. Septic arthritis. Okay, we just started to talk about septic arthritis. Leg calf perches, per these, yes. So per these, okay, great. So this is idiopathic osteonecrosis or leg calf per these of the femoral head. Okay, basically what we're seeing here is sclerosis of that femoral head and flattening. Leg calf per these is an osteochondrosis. We'll talk a little bit about that. What you can also see, depending on the stage, is fragmentation. You can see involvement of the femoral neck or femoral metaphysis as well. So leg calf per these and other osteochondroses that you've heard of, like Osgood-Schlatter, Sever's disease, they all basically have the same pathophysiology. And what you have is an abnormal growth of the epiphysis or an epiphyseal equivalent, so the apophyses or the round bones. And so there might be some delayed ossification. They all have poor vascularity, so they're vulnerable blood supply, and that results in AVN. But these kids are also very busy, and so because of the increased activity and the trauma, that can contribute to the osteonecrosis. And the epidemiology, it's seen in boys more so than girls. And the peak age for leg calf per these is 5 to 6 years, and in 15% of the cases, they can be bilateral. So, but you heard Dr. Jagadinsky say, one view is no view. And that's true. We always want to get two views. And so we want to look at the frog leg lateral view. And that's because the earliest involvement is going to be in the anterior femoral head. That's the most vulnerable. So you're seeing that there's increased flattening and actually subchondral lucency there in the anterior femoral head. So this is an MRI, a sagittal MRI with the fat suppressed and gadolinium contrast has been given. And so you can see that in this case of leg calf per these, there's a large area of the femoral head that's not enhancing. There's some patchy foci of enhancement, and there's some enhancement of the synovium. I'm showing this to you to show you, again, that the anterior part of the femoral head is going to be the most involved. So now here's a 13-year-old boy with left knee pain, and the knee films were normal. We'll get to the pathology, but some of you have probably noticed and are wondering, well, what is that gonadal shielding? What's that all about, right? And so gonadal shielding is actually no longer recommended by the Society for Pediatric Radiology, by the American College of Radiology, and there's several reasons for that. So the X-ray equipment we have has improved tons, and so compared to 1950, the doses are reduced by 95%, okay? The gonads are actually less sensitive than they were thought to be. So the gonads are on par with bone marrow and with colon. And so we're not shielding for the colon and bone marrow, so we don't need to shield for the gonads. Sometimes, as in this case, the soft tissues are not completely covered, or when we're trying to shield the ovaries can be anywhere, so it's actually not serving a purpose. At times, a lot of times we'll use automatic exposure, and so that can increase the dose to the surrounding tissues. And what that does is it terminates the exposure when the selected dose is achieved. So if the gonadal shield is obscuring part of the field, the dose is going to go up to try to achieve the correct dose. And also, a lot of times the anatomy may be covered, and so you actually need to repeat the film, which obviates the reason for using the gonadal shield. So let's go back to the hip findings on this. So you can draw something called Klein's line, and that is along the femoral neck and should go through the femoral head, which is normal on the right, and on the left you can see that it doesn't. So this is a case, and then also there is widening of that growth plate. So there's widening here compared to this. So it's more subtle on this, right? But this is a case of skiffy. But this is again to remind us to always get two views, right? And we want that frog lateral because now the findings are much more obvious. The widening of the femoral neck, and actually you can see this incongruity between the femoral neck and head. So this is a case of subcapital femoral epiphysis. So this is a Salter-Harris 1 type fracture seen in adolescents. They can be overweight or have delayed skeletal maturity. It's bilateral in up to 30% of cases. If you're seeing this in a child that's less than 10, then you have to screen for an underlying endocrine abnormality, hypothyroidism, hypopit, or there might be a history of radiation. And again, the lateral view is critical because 99% of the femoral necks are going to displace anteriorly relative to the neck. So if you get a report back from us that says normal, but this child still has hip pain, what do you do with that? If you're going to work it up yourself, you can send it to Orthopaedics, but if you're going to work it up yourself, what you can do is get an MRI, right, to rule out something called pre-slip capitofemoral epiphysis or other pathology. And so the pre-slip, and this is a fluid-sensitive sequences. So both these sequences, the fat is suppressed, and everything that's bright that we're seeing is fluid. So what you can see here on the in this kid, this is from the literature, is this increased fluid signal along the physis on the left, which is abnormal relative to the right. And also here you see irregularity along the physis and increased fluid signal. So this is a pre-slip capitofemoral epiphysis. I just want to go over terminology again because we've heard this over and over, just the terminology of the bones. So the epiphysis is the ends of the long bones, and they form the surface of the joint, okay? The growth plate, or the physis, is cartilaginous, and this proliferates and contributes to longitudinal growth of the bone. The metaphysis are the funneled parts of the bone, and they have the newest bone adjacent to the growth plate. And then the long tubular portion is called the diaphysis. I know that's review for most of you. So this is a wonderful concept, the banana and peanut butter model. And this was shown at a conference by Dr. Tal Leor, who is a thought leader in pediatric MSK and just brilliant. And so I've gotten this from her. And it shows you why pediatric bones are different from adult bones. Okay, so let's imagine the cortex. The cortex is the surface of the banana, so it's more porous than that of an adult. And then you've heard us talk throughout this afternoon about the periosteum. So the periosteum is the banana peel, and it's giving support to that cortex, right? It's gonna make it malleable and more elastic. That's why you're gonna see things like the buccal fracture. And then the perichondrium is the periosteum, which then goes over the physis. So it's a collar around the physis, and it's gonna provide support for that growth plate. And so the peanut butter is the growth plate, okay? So, and then the wire is gonna be the muscle tendon unit or the ligament. So it's obvious that the weak link is gonna be the physis. And so the bone is gonna fail before the muscle tendon unit or the ligaments, right? So going over the Salter-Harris classification, I know you've already heard it. It's just one other way of looking at it is this mnemonic. So mnemonics work for me. And the mnemonic actually spells out Salter, going from 1 through 5, okay? So Salter-Harris 1 fracture is a skiffy that we just saw. You have widening or slippage along the growth plate, okay? So if we have the metaphysis on top, as in this diagram, the physis, and then the epiphysis below, if you orient it that way, then above, the fracture line is going through the metaphysis into the growth plate, okay? Lower, it's going through the epiphysis into the growth plate. It's going through the metaphysis, through the growth plate, and through the epiphysis, and then it's an intra-articular fracture as well. And then this is erasure. It's a compression fracture. This is not something we typically see acutely. So children will come back in later and then we'll realize that they must have had an injury. So, and the higher numbers are not, initially they were thought to denote higher energy fractures, but that's not true, and they don't necessarily predict outcome. So injuries to the physis, pediatric in children involve the growth plate like up to 30% of the time. 5 to 10% of these can result in growth disturbance. It's seen in boys more so than girls because in boys the physis closes later. And it's more common during growth spurts. Remember I talked about that perichondrium going around the physis? Well, that involutes during growth spurts. So, and also the mineralization of the physis, the growth is going to outpace the mineralization. And the most common sites are the distal radius, the distal humerus, the phalanges, and the distal tibia. So here's a 5-year-old that comes in with a fracture, and you can see the fracture goes from the metaphysis through the growth plate into the epiphysis and through the joint space. And so this is a Salter-Harris 4 fracture. So here's another 13-year-old girl that comes in with knee pain. Okay, so here's the ugly. You have this aggressive lesion that's centered in the metaphysis. It has a wide zone of transition, which means that we can't really draw a line around the border. There's aggressive periosteal reaction, and there's this cloud-like bony matrix. And so this is an osteosarcoma. It's the most common primary bone tumor in children, and teenagers are most commonly affected. It likes the knees, so 60% of them are going to occur around the knees. Okay, it's usually based in the metaphysis. You're not going to be working up, the oncologists are going to be working it up, but we do image the entire bone with MR to look for skip lesions, which can be seen in 25% of this. Okay, so here are two 10-year-old girls with heel and ankle pain. Can you tell which one of these is abnormal? Just look at them. I can't tell which one is abnormal, right? So what are we seeing? We're seeing sclerosis of the calcaneal apophysis. If someone might say 2 because there's more fragmentation on patient 2, right? But what we have to realize that in the growing bones, when you have multiple vessels supplying an epiphysis, you can have fragmentation as a normal variant. And so sometimes we'll get these requisitions for rule out severs, and that's not a diagnosis you can make on X-ray. Whereas on MRI, on patient 1, you can see that there's this exuberant marrow edema. This is a fluid-sensitive sequence in the calcaneal apophysis, in the calcaneus, and in the surrounding soft tissues, right? And patient 2 looks absolutely normal. So the X-rays are not diagnosis. This is severs. This is another osteochondrosis. It's seen in children 9 to 11 years of age, and again, they're very active. The MRI is going to show the edema in the bone marrow and in the surrounding soft tissues. So we can add to our differential diagnosis Salter-Harris type fractures, osteochondroses. We've looked at leg calpurnias and severs, as well as neoplastic etiologies. Okay, so let's go to variant 3, where you have no localizing symptoms, but you do have concern for infection. So the ACR criteria says that an MRI of the lower extremity without or with and without contrast is usually appropriate, and other things may be appropriate. So what do you order? So in younger children that can't localize, this is recommending getting an MR of both lower extremities, okay? And that's done in the same way we do the whole body MRI. In children that are 2 to 6 and even older, they're probably going to require sedation or anesthesia because this is a longer exam. I'll show you how we do it. And the options are going to be without contrast or with and without contrast. So what about rapid MRI? Rapid MRI is something that we do for rule out appendicitis. We do for brains, looking at the ventricles to check the size of the ventricles, or for other reasons for the brain. And it's something that's now gaining traction in musculoskeletal. In our institution, we do rapid MRIs when we can for osteomyelitis and also for trauma. So there was this interesting presentation from the Pediatric Orthopaedic Society of North America, which looked at the use of rapid MRI for acute pediatric musculoskeletal infection. What they did was they compared traditional MRIs with sedation, with the standard sequences, with contrast to a rapid MRI, which basically use fluid-sensitive sequences to look for fluid and edema, diffusion sequences to look for purulence, and these were done without sedation. And what they looked at was MRI access, timing to treatment, length of stay, and charges, and found that with the rapid MRI protocol, the children could get to MRI in 1/3 of the time, 2.2 hours compared to 6 hours for the traditional. The duration of the scan was also shorter. The order time to the final interpretation was cut in half. The length of the hospital stay was reduced from 5.3 days to 3.7 days. These are all median numbers. And the charges were also reduced from $32K from $47,000. So this is how we do our MRI of the lower extremity. Both limbs are placed in the magnet, or we're imaging both limbs with the coil, and we jump. So we have one station as far as we can get, and then we jump down to the next station. And so depending on the size of the child, you'll have multiple stations. So we do a coronal fluid sensitive sequence, and then we'll do an axial fluid sensitive sequence and an axial diffusion weighted images, and if we need to, give contrast. So sedation is usually required for the younger children. And then here you can see that if we see something on the edge of the field, what we'll do is we'll cone down and get a smaller field of view to actually look in the feet in particular. So what I'm going to do now is just go through some of the things that we see. And so here's a 5-year-old that comes in with a limp. And you can see that there's marrow signal abnormality in the distal femur and in the proximal tibia, and so that's osteomyelitis. There is also a subperiosteal abscess collection. This is a post-contrast along the distal femur and also along the proximal tibia, and we can see that as well here. So this is MRSA, and we already talked about the pantene valentine leukocidin gene, and so what that codes for is multifocality, as well as abscesses, and I'll show you another example too. So the next example is an 8-year-old with knee and chest pain. So you can see on this post-contrast image that there's diminished enhancement relative to the normal marrow within the proximal tibia, which goes along with osteomyelitis. There is also a soft tissue abscess here that is not enhancing. Oh, but wait, there was this bright signal that was observed. You should have normal flow voids, and here you can see it as a filling defect in the femoral vein going all the way up. Okay, there was this. So since she had chest pain, they moved the coil up and looked at the chest, and you can see here that there was something in the lungs, and this ends up being a DVT with septic emboli. Okay. So what we'll see with this protocol is usually infection. Here's a 2-year-old that comes in with a fever and a limp. So we can see that the navicula is not ossified. And within that unossified navicula, there is this area of signal abnormality on our fluid sensitive sequence that's bright. And on the sagittal film, you can also see again here on the fluid sensitive sequence that there's that area of T2 brightness. And then following gadolinium, it enhances, and then there's exuberant surrounding soft tissue enhancement. So what is this? It's not osteomyelitis, it actually ends up being an infectious chondritis, and the organism here is Kingella kingae. So in the younger kids, like Dr. Sabatini said, when we get culture negative, a lot of times these infections are probably going to be Kingella. So what other things can this protocol find besides infection? So here are 2 patients with lower extremity pain and elevated inflammatory markers. So on the left, we have this 4-year-old that has multiple foci that show marrow signal abnormality. We can see the soft tissues are also abnormal. And then on this child, there is marrow signal abnormality on this fluid sensitive sequence in the femora, in the pelvis, but there's also muscle signal abnormality adjacent to the femora and in the pelvis as well as subcutaneous subcutaneous edema-like signal. Okay, so on the left, we're seeing neuroblastoma mets, and on the right, leukemia. And finally, for this category, this is a 3-year-old with a limp. Okay, so this is a fluid-sensitive sequence, and we're seeing a joint effusion. Okay, and then following the administration of gadolinium, there is this shaggy appearance of the synovium that's enhancing. So of course, with a joint effusion and synovitis, the first thing we want to exclude is going to be septic arthritis, but the differential is going to include transient synovitis, other inflammatory etiologies like hemarthrosis in the appropriate clinical setting. But in this kid, we can see that there are these small, dark filling defects, right? So these are actually rice bodies, which is a sign of chronic inflammation. And this was a case of juvenile idiopathic arthritis. So to our differential, we can add leukemia and neuroblastoma, another metastatic disease in the marrow. For infection, we've seen various manifestations of osteomyelitis in the rheumatologic category, juvenile idiopathic arthritis. Okay, so acutely limping child variant 4. So this has localizing symptoms in the hip, and there is concern for infection. So appropriate first line of imaging can be ultrasound of the hips, that's usually appropriate, and MRI of the pelvis without contrast or with and without contrast. And then other things may be appropriate. So here's a 5-year-old girl with right hip pain, inability to ambulate for 5 days with fever and leukocytosis, elevated SED rate. So what are we seeing here? We've done an ultrasound here, and this is different from your DDH ultrasound, looking for a joint effusion. So the transducer is placed along the femoral head and neck anteriorly. So on this side, this is the metaphysis here and the epiphysis up here, and you can see that the joint capsule is distended out as compared to the normal side, the contralateral side. Okay, so this is another joint effusion. We can't tell you what's in the joint, but the differential includes septic arthritis, transient synovitis, and everything else we said before. So for this child, her clinical course, So she had elevated fever, elevated white count, elevated sed rate, elevated CRP. So she bought herself a trip to the OR. And what was found, so she underwent an aspiration and washout procedure. The fluid was purulent and the culture was methicillin sensitive, Staph aureus. Because she had persistent elevation of inflammatory markers, she then went to MRI. And what we see here is this modeling appearance of the marrow, this compared to the normal marrow on this fluid sensitive sequence. Okay, so that's osteomyelitis. And we heard that in over 50% of septic hips, you can have osteomyelitis. There's also signal abnormality in the muscle, so that's myositis, as well as subcutaneous signal abnormality, and I'll say fascial abnormality too. So there's cellulitis and fasciitis. She didn't have an abscess, so she was treated medically. So now we can add the septic arthritis to the osteomyelitis in our differential diagnosis. So variant 5, so symptoms in the lower extremity, not pelvis or hips, with concern for infection. So MRI of the lower extremity area of interest is a reasonable place to start. That's with or without contrast, and other things may be appropriate. So this 5-year-old was limping for 2 weeks. You can see that there is a lesion in the proximal femur. So here it is. There's exuberant surrounding bone marrow edema. It enhances following administration of contrast. There's also surrounding enhancement. The sagittal view of the spine, because there was also back pain, the spine was obtained. There is collapse of one vertebral body. There's actually soft tissue extending into the epidural space and compressing the spinal canal and the spinal cord. So this is Langerhans cell histiocytosis, an abnormal proliferation of histiocytes. It's a benign lesion, but radiographically aggressive. And we can see punched out lesions, usually in the diaphysis, classic beveled edge abnormality in the skull and vertebral plana. So this 10-year-old female with leg and back pain. So what are we seeing here? We're seeing signal abnormality in the proximal tibial metaphysis, actually extending into the epiphysis as well. So metaphyseal involvement. Well, she has this destructive expansile lesion of the clavicle. There's no associated soft tissue mass because Ewing's would be in the differential for this, but there is surrounding edema. And then for her, she has multiple areas of vertebral signal abnormality, and she also has vertebral plana. So you probably already know what this is. This is chronic non-bacterial osteitis or chronic recurrent multifocal osteomyelitis, which is uncommon. It's an autoinflammatory disorder, typically seen in females. Median age of onset is 10 years of age. It's usually multifocal and symmetrical, centered in the metaphyses or metaphyseal equivalents. And that clavicular lesion is almost pathognomonic for CRMO, and it's a diagnosis of exclusion. Lab findings are usually negative. Autoimmune markers are usually negative. Cultures are negative, and biopsies should be sterile. Again, it's a diagnosis of exclusion, and the treatment aim is to treat the pain with the anti-inflammatory drugs and steroids and monitor these patients, usually with whole body MRI for spine involvement or other bony involvement, and the treatment is to preserve, with the goal to preserve function of adjacent joints. So unfortunately, these patients don't do well. A majority of them continue to have persistent disease, may have permanent bone deformities, chronic pain, and a reduced quality of life. And a small subset will outgrow this post-puberty. Okay, so you all know who this is, right? Yeah. So once you see this, you can't unsee it. So for my last case, I want to look at a chronic, a CRMO doppelganger. This is a very interesting case. So this is a 6-year-old with developmental delay and worsening leg pain over 2 months. So total body MRI was done. You can see that there are metaphyseal abnormalities in the proximal humerus, distal femur, proximal tibia, and distal tibia. This was really a diagnostic dilemma for multiple services in the hospital that were trying to figure out what was going on with this child. The sagittal spine also shows lesions in at least two vertebral bodies. So the hospital course went like this. Laboratory values were significant for elevated sed rate and CRP. So not what you expect with chronic non-bacterial osteitis, and also not the wrong age, right? So he had a biopsy. It was negative for bone marrow infiltrative pathology. Then he developed pulmonary hypertension. He was admitted to the PICU and following intubation developed oral bleeding. ENT took him to the OR for control of the oral bleeding. And then further laboratory values were revealing. People know what this is? Anyway, his vitamin C levels were negligible. So further history obtained found that he had a very restrictive diet and would only eat pirate booty. So this was scurvy. So now to our differential, we can add Langerhans cell histiocytosis. It's not neoplastic, but I've put it in that category. Chronic non-bacterial osteitis, and then in the metabolic category, scurvy. So in summary, we've reviewed the initial appropriate imaging in the acutely limping child, using the ACR appropriate criteria as our guide. We've looked at cases of trauma, starting with the leg films for that variant 1. Looking at the toddler fracture, we also know to look for the trampoline fracture and the toddler fracture of the cuboid. We've talked about Salter-Harris fractures, really emphasizing getting at least 2 views for that for any pelvic film and getting 2 views for any kind of study that you are getting. And then leg Calf-Perthes, we've talked about osteochondrosis and leg Calf-Perthes and severs. Severs is not an X-ray diagnosis. The ugly to include tumors like osteosarcoma, leukemia, metastatic disease. Langerhans cell histiocytosis is also there. Rheumatologic conditions to include juvenile idiopathic arthritis and chronic non-bacterial osteitis. Infections, septic arthritis and the changing face of osteomyelitis, as well as the metabolic etiology to include scurvy. So in summary, we've described the indication for different imaging modalities and built an appropriate imaging algorithm for the acutely limping child, and also went through a differential diagnosis for common and uncommon etiologies of the limping child. Here are my references at the very bottom. That's the ACR portal, the link to the ACR portal. So thank you.
All right, we'd like to invite Dr. Sabatini back onto the podium for any questions. Yes.
Yeah, so in the old days, we used to do lots of lab work on the translating to the bias and this is septic hip. And then recently we sort of shied away from it. And I'm listening to you and I'm like, oh no, we're going back. I mean, clinically you can have good follow-up, you can have toxic, are you okay not doing that initially?
I think it depends on your physical exam. I think physical exam history is everything, right? So if you have a kid who is sick looking and refusing to bear weight and has pain with range of motion of the hip, you should get labs. If you have a kid who's like came in and is doing a little bit of this, but you range their hip and they don't seem to really have pain and they don't look sick, I'm 100% okay you're not getting labs, right? I think we can't ignore the history, the physical exam, because that's what's going to guide those things. I do think though that it's good then to check. I mean, again, if it's this kid and everything else was fine, you don't need to call the family the next day. If it's a kid who you're sort of, I don't really know, just check back in with them or encourage the family, just teach the family to let us know if there's a problem. Can I just tell everybody how much I love Dr. Kammen and how blessed we are to have her at Oakland Children's. Okay, sorry. Any other questions? Any other riveting things? I might just have to point out for the people who said skiffy for that one thing instead of Perthes, that let me have this be a teaching moment that we don't really see slip capital femoral epiphysis in children under 8. So I think that was a 4-year-old.
Yeah.
So 4-year-old with a abnormal looking femoral head. But anyway, a 4-year-old is going to be Perthes until proven otherwise. A skiffy doesn't usually happen until you have somebody over the age of 8, and really usually over the age of 10. Although when you have young females, for example, those who are starting their menses at age 9, they absolutely can have a skiffy when they're younger because that's the sort of skeletal maturity that they're at. So anyway, Perthes in the young, skiffy in the older. Yes?
Talk a little bit about Perthes, like how progressive or urgent is that? Or
Lord have mercy. Yes, I will just say that Perthes is not urgent. So Perthes is so if you have a patient who comes in with like atraumatic pain and their exam is not at all concerning for infection, and you do the wonderful, series of AP and frog lateral that you were instructed to, and it comes back as Perthes, that is not like urgent like that kid doesn't need to go to the ER. That kid doesn't even need like urgent ortho evaluation. You can see them within a few weeks. The family needs education and like probably some additional imaging, but it is not an urgent problem. It's a sort of chronic condition that we manage over time. And in some cases it needs surgery. So that's why it needs to be managed by an orthopedic team, but it's not urgent. Skiffy. So if you thought a child has a slip capital femoral epiphysis, that's not a child that you send to outpatient, well, you can send them to outpatient radiology if they can walk. But once it says that it's a skiffy, that is urgent. So if that's a Friday night patient and you get a result back that the kid has a slip capital femoral epiphysis, you have to call the family, tell them not to let the kid walk, get the kid to the ER, and we'll probably fix them the next day. So slip capital femoral epiphysis is urgent because even if it hasn't slipped, if they walk wrong and twist and it does slip, that becomes an absolutely catastrophic problem. Nobody likes to head off their femur. That can both lead to bad range of motion in the future and also complete loss of the femoral head, just like I showed you with the septic arthritis. I'm happy to talk more about Perthes, but
We'll put it on the agenda for next year.
yeah, hips, pediatric hips are one of those things that are it's an important topic to talk about because there's so much pathology in the child's hip that could be, and so it's really important to focus on like what are the urgent things like septic arthritis and skiffy, and what are the not so urgent but still need referral things like Perthes and avascular necrosis in the setting of sickle cell and things like that. So thank you for that question. Anything else? Yes, in the back. Speak up, don't hear well.
What kind of those patients tend to come in like a traveler, like the big
I should not have played drums in a heavy metal band when I was young. Oh, it's actually probably everywhere. So Kingella is very, it's probably pretty ubiquitous. There's studies out of Israel and out of Chile that have both shown really high rates of Kingella, but that's because they checked for it, right? So just like you saw an example of a navicular Kingella chondrite, that was super cool, by the way. I've actually never seen that. But Kingella is probably here everywhere. We just don't test for it very often. So if you have a kid who's sick, who's not responding well to treatment, and your sort of initial culture and sensitivity didn't really tell you anything, run the special Kingella test, because we can do it. It's just like a blood agar plate and some call in Petru from infectious disease, and she can help you out. But yeah, so just check for it. Sorry. I can't stand, sit still, I gotta dance. Yes! Oh, I thought Michelle Capella had a question, I was really excited.
Michelle? Alrighty. Well, that's a wrap for day one. Thank you everyone for sticking around. We had a good session today. Come back for more tomorrow for some pediatric sports education. Alright, have a good night.